you. Thank you. It
Okay,
is.
thank you. So I've been asked to talk about the assessment of pulmonary hypertension using the latest guidelines. These have become to the prominence recently, and we'll go through this in some detail. So we'll do a very quick summary of the definitions of pulmonary hypertension, why there's been a change in the guidelines. We'll do some assessment of structure and function that we need for the pH assessment. I've got some nice case examples, I hope, for you, and we'll end up with a quick summary. So we know the mean pulmonary artery pressure on invasive assessment over 25 millimeters is considered significant pulmonary hypertension. And for decades, we've been using echocardiography by estimating the TR velocity and the right atrial pressure using the Bernoulli equation. And of course, there is a problem with this because whatever number we get, we square and then multiply by 4. So any error is multiplied significantly. Now we know echocardiography can therefore overestimate and underestimate the pulmonary artery pressure, and the agreement with catheter studies has been poor. So the latest guidelines suggest we should limit echocardiography to determining a probability of pulmonary hypertension and avoid spending too much time to estimate the pulmonary artery pressure itself. So the basic classifications you'll all know about, class 1 is pulmonary arterial hypertension, secondary to left heart disease for class 2, class 3 is the lung disease, the chronic thromboembolic pulmonary hypertension, and the unclear versions. And the important point from this slide is working out the pulmonary artery pressure, knowing what your what the wedge pressure is. Because if you have high left atrial pressure due to any form of left heart disease, that is actually very important to determine on the echocardiogram. So these are the guidelines that have been produced. Now, this is the British guidelines, but the Americans and the European guidelines are very similar. I'd highly recommend looking at this document. It's very helpful. It's a very well written document. It basically says, look at the TR velocity. If you're over 3.4 meters per second, you have a high probability of pH. If you're less than 2.8 and have less than 2 categories, now the categories are mentioned here at the bottom. You have A, B, and C. You need any one of A or B or C. So any 2 out of these categories immediately puts you in the intermediate risk if you have a low velocity. If you're intermediate velocity, use the same 2 categories, and that tells you whether you're intermediate or high risk. It's a very, very straightforward, very simple approach. And the assessment of the ventricles, the PA, and the IVC, I'm going to show shortly. So when it comes to the ventricles, all they're interested in is the eccentricity. Are you seeing a flat septum? If you have a flat interventricular septum, you have ticked 1 point for an echo criteria for raised pulmonary artery pressure. And the other ventricular assessment is your RV diameter at the base bigger than your LV diameter at the base? Again, it's very straightforward. If the RV is bigger than the LV, you tick another point. On the PA parameters, a PA diameter of more than 25 millimeters. If you measure your PR velocity, you take an early PR velocity, anything more than 2.2 meters per second counts as an indicator of raised pulmonary pressure. RVOT acceleration time less than 105 milliseconds is a very good indicator of a raised PA pressure. And don't forget this mid-systolic notch. This is a very useful indicator of a raised pH. So if you've got any one of these, that again counts under your PA parameter for your guideline. And then the last thing they ask you to look at is the IVC. So IVC and RA together, if your IVC is more than 21 millimeters and there's a less than 50% reduction with your sniff test, you will tick 1 point. Or if your right atrial area in end systole is more than 18 square centimeters, so big right atrium, that's another alternative way of getting your point. So I've got some cases lined up for you. So I'll talk through all of this. So these are just cases that we've had coming through our department in the last few weeks. Straightforward, we get the impression straight away that the RV is bigger than the LV. So straight away, you've got one of your minor echo criteria, if you want to call it that we don't have any significant mitral valve regurgitation. You get the feeling there's a flat septum here. So maybe we've got, again, 1 point on the ventricular side because the big RV and the flat IV septum all count as 1 point, not 2. There is some tricuspid valve regurgitation, as you'd expect. and the TR velocity comes out at 4.6 meters per second. So we're well above that 3.4 meter per second cutoff. So straight away, we will follow that algorithm shortly, and I'll show you how it all works. Mitral inflow is impaired. We can see there's going to be significant diastolic dysfunction. There's a very tall E wave and a very sharp deceleration time. So again, this now tells us, is there something going on in the left heart that's causing the right heart raised pulmonary pressure? And the final shot I've given you is the IVC. We can clearly see that's a big dilated IVC. The hepatic veins are very clear. I don't need to do the measurement. We all know that's going to be enlarged. And there's a less than 50% reduction when the patient's taken a sniff. So how do we integrate all of these bits and pieces together? So first of all, TR velocity more than 3.4 meters per second. So straight away on the right-hand side, as I see it, that means we've got a high probability of PH. We can actually stop thinking if you want to, but we don't. We keep thinking. This patient's in AF. They have severe diastolic dysfunction and have a dilated and impaired RV. So we will conclude to say this patient does have a high probability of pulmonary hypertension, and this is due to left heart disease. This is severe diastolic dysfunction, AF, and this dilated and impaired RV is an adverse prognostic factor, and therefore we give additional information, not just saying this patient has a high probability of PH. So, case B. This is another patient that we saw just a few weeks ago. Now, I see a case of this every 3 or 4 years in my practice. I'm guessing you see 3 or 4 patients like this every day. So clearly we can see this patient has rheumatic mitral valve stenosis. We definitely have a flat interventricular septum. There's some mitral regurgitation, and you can clearly see on the 4-chamber view, lots of flow acceleration due to the mitral stenosis. When we look at the RV, it's definitely bigger at the basal level compared to the LV. So we have some criteria straight away that suggests this patient has some pulmonary hypertension. There's clearly tricuspid regurgitation. When we measure the TR velocity, it's well over 3.4 meters per second, so straight away into the high risk group. The IVC is dilated. There's less than 50% change in respiration. So this again is a very straightforward example of following the guidelines. The TR velocity, definitely more than 3.4 meters per second. We're straight down this arm of the pathway, high probability of PH. And in this patient, we know they've got severe rheumatic mitral stenosis, as well as a dilated and impaired RV. It's this dilated impaired RV, which you know is an adverse prognostic sign. So again, this is another patient who's got a PH diagnosis. It's a high probability, that's clear. And this is due to left heart valve disease. And given the impaired and dilated RV, we know straight away that's an adverse prognostic factor, and this patient needs to move on to urgent mitral valve surgery. So hopefully these 2 cases are very straightforward. This is another patient I look after. She's 89 and she's breathless. You can clearly see it's an abnormal heart. On the parasternal view, big dilated RV, some septal flattening. It's very clear septal flattening on this particular view. So there's clearly going to be eccentricity. Dilated RV we've noted already. Mitral inflow isn't too bad. For an 89-year-old, this is actually pretty good. So just some mild diastolic dysfunction. We can measure tissue Doppler and everything else, but this is still just mild diastolic dysfunction. Her left heart is not the problem in this particular case. Of course, there's tricuspid valve regurgitation. The TR velocity in this patient is more difficult. This is more of a real-world case. It's difficult to know exactly where it is. We could give saline to augment the Doppler flow, but in this case, we were pretty happy to put it about here. It's in the intermediate range. It's more than 2.8. It's definitely less than 3.4. Her IVC is not dilated, and it definitely collapses very nicely. When you measure her RV outflow tract velocity and VTI, we can clearly see that mid-systolic notch on the bottom panel. This mid-systolic notch is one of those criteria for raised pH. So this patient has a TR velocity that's between 2.8 and 3.4. They're straight down the intermediate group. We now need to look at our echo categories. So do you remember, ventricle, dilated, flat septum, that's 1 point. The second one is the everything to do with the pulmonary artery. Is it dilated? Do we have the mid-systolic notch? Do you have the PR more than 2.2 seconds, meters per second? And then the final one is IVC RA. Is the IVC dilated? Is the RA dilated? Now, in her situation, her IVC is not dilated, but the right atrium clearly is dilated. And in this, so this counts, and she actually has all three categories. So straight away, she falls down the middle and then straight into the high likelihood of pulmonary hypertension. She's in sinus rhythm. She does not have left heart disease, but she does have a dilated and impaired RV. And actually her diagnosis is severe pulmonary hypertension or high probability of pulmonary hypertension. And she was a patient with CTEPH, chronic thromboembolic pulmonary hypertension. The dilated RV is interesting. I think that's chronic, but the small IVC is because she'd been diuresed. She'd been admitted to hospital with peripheral edema and was aggressively diuresed by the admitting medical team, and therefore that's why her inferior vena cava was small, and that explains that, small and narrow, that explains that example. So the final case I have is another patient just seen very recently, again, big right ventricle. We've already seen a case of this in the tricuspid valve talk. You can clearly see a fixed open tricuspid valve on this RV inflow view with torrential TR. A good functioning left ventricle without, so there is no sign of septal flattening. And again, another view of this tricuspid valve, which is very fixed. So you'll all know the answer. When we look at these views here, on this sort of modified apical view, the left heart is working very well, big dilated RV, that's straightforward. Again, we get another view of this torrential free flow TR and some TS as well. Her mitral inflow isn't too bad. This lady's in her late 60s, early 70s, so for the UK that's pretty good. And then we see the TR. Now the TR on this is very intense, dagger shaped. And when you see something like this, this is only this flow picture is only with torrential TR, and we're well under the 2.8 meter per second criteria. It's difficult to see this lady's IVC, but you know, I'd say that it's not particularly dilated. We don't see the hepatic veins. This is one of the patients where it's a bit more of a challenge, but we do see her pleural effusions quite nicely on this scan as well. So this lady's TR is less than 2.8, so she goes straight down into this lower end category. Does she have two echo categories? So her RA is dilated and the RV is dilated, so she actually fulfills two categories and comes under the intermediate probability of pulmonary hypertension. She's in sinus rhythm. We know she doesn't have left heart disease. And it's a dilated and not impaired RV. That RV is working quite well. And this is someone with carcinoid tricuspid valve disease. She has torrential TR, and this is someone with volume, not pressure overload. And this is an example of where this guideline doesn't work perfectly. And we have to remember this is a guideline, not a rigid protocol. This patient does not have pulmonary hypertension, but the torrential TR makes it very difficult to assess PA pressure. And although she does fall officially under the intermediate guideline or intermediate likelihood of PH, most of us would agree she's not going to have pulmonary hypertension. This is a straightforward case of carcinoid tricuspid valve disease without pulmonary hypertension. This is a volume loaded hyperdynamic system, not pressure loaded. So I'll go through these guidelines again. We look at the TR, you measure the velocity, and if it's anything less than 3.4, you have to look at your echo categories. And the categories are based on ventricle or PA or IVC RA. If it's ventricle, it can either be eccentricity or a dilated RV. If it's PA, look at your velocity, remember, an acceleration time less than 105 milliseconds, or that mid-systolic notch, or the high PR velocity, or the dilated PA. Any of those gives you 1 mark. And for the IVC, a big RA area and a big IVC with reduced respiratory change. You only need 1 point from each of these groups, add them up, more than 2 echo categories, it immediately pushes you from either low to intermediate or intermediate to high probability of pulmonary hypertension. So in conclusion, using echo, now we're going to suggest we just measure determine a probability of pulmonary hypertension. We're not so interested in the absolute values of what we think the PR pressure is, to what we think the PA pressure is. It's over 3.4 or less plus 2 of these parameters. Echo's brilliant at determining the etiology if it's due to the left heart, and I've given the example of someone with diastolic heart failure causing pulmonary hypertension, or if they've got a shunt. Clearly anything like this is where echocardiography comes into its own. If they've got pure lung disease, it's more challenging to determine what's going on. But we can also determine prognosis if the RV is dilated, if there is RV dysfunction, by whatever method you want to use. So feel free to do RV tissue Doppler, look at the S-wave. If you find RV dysfunction with RV dilatation, they're immediately in a poorer prognostic group. I would strongly recommend looking at the guidelines. This is one example of them from the British Society. The European and American guidelines are very similar, but they all say the same thing now. We should determine probability. Don't get worried about absolute values of PA pressure. Try to determine the etiology, especially if it's left heart related, and try and determine the prognosis, because that is important. I'm going to leave you with this quote from a very famous physician who worked in the UK. Medicine is the science of uncertainty and the art of probability. Thank you very much.